Diversity, Inclusion and Health Psychology podcast. In this episode, we're joined by Professor Marie Johnston, I will let her introduce herself. Welcome, Marie, to the, have I pronounced that correctly, by the way, Marie? It's interesting. We'll come on to names in a second, but yeah, please, have I introduced your name correctly and tell us a bit about yourself.
Thanks, Joe. I'm Marie Johnston. I'm Emeritus Professor at the University of Aberdeen, and I've been involved in health psychology and conducting research on a great variety of issues for quite a long time. And part of my research interests have been in looking at disability and how psychological models work with understanding the behaviour of people with disabilities. But I have a big range of things that I do, including behaviour change interventions.
And thank you so much for joining our podcast and the conversation. And in this episode, we're discussing our relationship with the built environment. I'm sure we're going to go into that a bit more later. But I wanted to start with this important question that I ask normally all guests, is the importance of equality, diversity, inclusion in health psychology. How important is it? Why do we need to, in your opinion, explore this, or we need to consider this as we consider health psychology, both for our current psychologists, health psychologists, and also aspiring future health psychologists?
Our subject is basically about understanding people and their relationship to health and healthcare. And if we do this in a biased way, we're only talking about the health and healthcare of some people and not of others. We're talking about how some people look after their health and how other people look after their health. We're creating different series for different segments of our population, so that basically our theories need to be relevant to everyone, or we're missing a big part of our scientific discipline. And we need a representation from the range of people that can help us to contribute to that. Having said that, as a discipline, we're very biased towards the Western science and Western countries. So we always have these biases, and to some extent we try to correct them, but I don't know how well we're doing.
Is it something that's always been a problem then, or has always been an issue about, or is it something that's come up more recently, would you say? About inclusivity, for example, has it always been a problem? Like, okay, well, we've always had that problem and we've always discussed it.
I don't think we've always discussed it, because we haven't actually worked out, our discipline is too recent to have worked out really how we do it. I think to some extent we've been working out what we're trying to do, and what you're talking about is how we do it and how we make sure that we're covering the whole of our discipline and involving everyone who should be involved in it. So I think it's gradually become more important as we've become clearer about what the content of our discipline is.
That's interesting, isn't it? Like, in terms of our curriculum, right? About how that will be shaped in the future, or what's happening right now. So what was it like when you first came across, I suppose, the discipline of health psychology, when you start studying it or looking into it? Is it very different to what it looks like today?
I can give you one very distinct, a couple of examples. One was when I first became president of the European Health Psychology Society. I personally didn't notice this, but when they took a photograph of the committee, I was the only woman. I was the president and the only woman. And so that tells you something about how things were organised. And it's not the case that there was a shortage of women in the discipline. There was a shortage of women in the leadership roles in the very usual kind of way. So that was a major thing at that time. I'm trying to think about other things that were particularly biasing. Oh, the other kind of thing that happened, but I think this still happens. Trying to arrange a conference and going to a conference venue. And I was always very insistent that conference venues had to be accessible to people with limited mobility. And early on, it was just about acceptable to make it quite difficult for people in wheelchairs. They had to go by different routes to venues. And there was one particular conference venue we went to, and they had no lifts, and yet the conference was going to occur on different levels. And when I raised this issue, they said, "Oh, we'll carry the people up and down."
Well, physically, like, wow.
So I said, "Well, I think we'll be taking our conference elsewhere." Their response was to say, "Okay, we'll give you a different building that has lifts." That was fine for us, but I assume somebody else was now dealing with the building that didn't have access. Having said that, I've just been to the European Health Psychology Society conference, and there was no access for people with limited mobility. So we had a colleague on crutches, and she couldn't get to the venues. She gave up. So
Wow.
I think there is progress in people being aware of the issues, but I'm not convinced that it's necessarily being solved just yet. It horrifies me.
Of course, well, this hearing it, it's like even just the thought of carrying people, even back then, if they had the idea, and even today, when we have all of the technology, equipment, knowledge, laws, like, you know, we have to make sure there's an app, and other spaces it doesn't happen. So why do you think it is the case? Just like, why do you think they do that then? Like, is it because you talk about self-awareness? Is it something that doesn't, like, it's not autonomous in their mind? Like, why do you think they're not considering that?
Well, it's a complicated issue because in the classic way, if you don't see people in wheelchairs, you don't think they need access. If you don't see people in crutches, you don't think they need access. But we're a health discipline. We should be aware of these issues, even though we can't see them. And we should be wondering why we're not seeing the people who have limited mobility. They don't come. And in a curious way, conferences conducted by Zoom created all sorts of equalities that weren't there before. But now we're back to in-person conferences. The discriminations are back in force. The Zoom conferences were good for people with all kinds of limitations. So they were good for people who had hearing difficulties. They were good for people who had difficulty seeing things. There were all sorts of things were handled much better on Zoom. I'm not arguing that we go for a whole world of Zoom or technical communications, but I thought coming out of that, we might have been aware of how much easier it had been to include people.
Because you've been involved in this space, so you can make the comparison, isn't it? So it's a fair comparison of like, okay, what was it like then, before COVID, if you like, when we went online?
Yeah.
And now you see that transition seem to be going back, even though despite the evidence.
Yeah, I don't know if we're going back, but I think there was such excitement at being together that people have forgotten the kind of rules that should apply to conferences about making it inclusive. I mean, there are still other things we don't make inclusive. There are conferences. I don't know that we have auditory loops so that people who have difficult hearing can hear. We certainly don't make it easy for people who have limited sight. And we certainly don't make it easy for people who have got mobility problems. Maybe we just needed to have it higher up our considerations. Because I've done research on disability, for decades. And so it's always been something that I've been concerned about, because I've been very concerned that why I focus on disability is, if you look at a large part of what we do when we talk about prevention in health psychology, which is a big issue, we talk about behaviour change for prevention. Yeah. Typically what we're preventing is the causes of death.
Yeah, quality of life.
Yeah, and so, well, quality of life, I'll keep on one side, because I think we're talking about very often about prevention from the lethal diseases. The same kinds of behaviour can be directed at reducing the amount of time people are disabled, but that hasn't quite been our focus. But it's always been my focus, because I've always thought that my personal feeling is that disability is more challenging than death, but death is inevitable. Disability and being limited in that way is not inevitable. And quite a lot of the limitation is not to do with what's happening to you physically. It's what's happening in your environment that makes you limited.
And what would you say, like, what motivated you to research this area? Is it something that you were that you saw, exposed to, came across in your field of studies? Like, what made you choose, like, this area was actually a big area that we need to address from your work?
I don't really actually know. I think probably because I got involved in a a project evaluating the impact of community hospitals. And if you get into community hospitals, you're typically not dealing with major procedures like surgery. You're dealing with a lot of it's to do with the kind of healthcare that's looking after people who are unwell or unable to do things for themselves. And I got involved in two kinds of study. One was looking at patients who were recovering from surgery, in which case you are talking about what are their limitations due to the impairments due to surgery. And the other study I got involved in was how community hospitals could help people who had physical disabilities. And there I was working clinically with the healthcare team involving nurses, physiotherapists, occupational therapists, and working with people in the community. And it was a fantastic position to be in because we were working with local people, and we could actually go and evaluate what their homes were like to enable them to be effective in their own environment. And as a clinician, I got very enthusiastic about doing that, so that quite a lot of the work was involved with the usual kinds of things that clinical psychologists are involved in. But for example, I also got involved in working with a woman who had a cerebellar tumour, which meant she lost her confidence completely and couldn't go out at all. And I just did a graded program which enabled her to overcome her anxiety and enabled her to walk the crucial distance that allowed her to walk to her daughter's house. And that was a very simple intervention where you just used a graded approach, so that we started off with her husband walking to within 10 yards of her daughter's, walking with her to within 10 yards of her daughter's house, and she did the last 10 yards, then she did the last 20 yards, until eventually she could do the whole journey by herself. So the clinical psychology principles were helping us to overcome limitations, which were partly due to the environment and partly due to the woman's anxiety because of the tumour making her unstable. So that's the kind of clinical things I was involved in that made me interested, and just seeing how the environment was contributing quite a lot to people who did have physical impairments, but also how they were treated by other people. There's a way in which it's this a dilemma between, are you trying to help people to do things or help them to do things for themselves? And this fascinating contrast between nursing and the other and the therapy disciplines, and that we always characterize it as the nurse would give you your cup of tea, the occupational therapist would enable you to make it. And that idea that the social environment would enable you to do things, as well as the physical environment. And we did quite a lot of studies contrasting the work of the physical therapists, the physiotherapists, the occupational therapists, and the nurses. And simple things like getting them to assess a person's limitations. The nurses always saw the person as having more limitations than the physiotherapist and the occupational therapist. We've got very good data on that. So the same patient on the same day was assessed as being more disabled by a nurse than by an occupational therapist. So the way in which they're viewed influences so much by how they're enabled to function within the healthcare environment. Sorry, I did lots of things that just engaged me. And some of it was clinical, and some of it was responding to problems in the hospital. And the other big thing was, of course, that a lot of psychology is involved with the unobservables, whereas behaviour is observable and disability is defined as limitations in behaviour. It is always limitations, so that the International Classification of Functioning and Disability is clear about impairments of structure and function. But the things that are critically important are activity limitations, limitations in the behaviours that one's able to do, and social participation in the social activities, participation in society. And those two are both behavioural. And so the idea that we can actually have as our dependent variable behaviour. And I wrote papers describing reviewing disability and reviewing disability as behaviour. rather than focusing on the physical impairments.
And in that sort of experience, or that example you're given, especially if I go back to what you said about the nurse and the occupational therapist, did they have their own individual assessments? And then and as a psychologist or as a person in psychology, because it might not have been refined at the time, did you add to that, or did you just input into theirs, if you like? How would that work, that assessment bit? Just passionate about that one.
It wasn't really the assessment bit that we focused on, but I think what we did do was we had very good conversations with the nurses about how they were on a sort of transition from the patient needing things being to be done for them to handing over to the patient doing it for themselves.
Yeah.
And that was quite a difficult transition. And it's quite important that if you have limitations and you're not able to do things, that you have people who will do things for you and enable you and look after you. And there's a transition to the point at which you're able to do it for yourself. And the nurses were having to handle that transition in the way that the physiotherapists and the occupational therapists are typically not so involved until the person is beginning to think about doing things for themselves. It was that kind of transition that we thought was important.
And do you think that that's understanding how these all components work is good for the relationship between us and the environment, how it all works?
So that is very much the social environment, yeah. But there's also the physical environment, that the nurses are seeing patients in a different context of hospital wards rather than the more accessible areas of the occupational and physiotherapy rooms, which are easier for people to negotiate who've got limitations because they're designed for that. But if you think about it, people with physical limitations on ordinary hospital wards, it's a very difficult environment for them to be in, because the staff, for example, on a surgical ward, they may have to deal with someone who actually arrives with some physical limitations. Can I just say that's also true of people with mental health problems?
Yeah.
But I was more involved in the physical health problems, that there needs to be slightly more alertness of how to look after people in those situations. I mean, there are very simple things about any healthcare problem that a person brings into a surgical ward can be difficult to incorporate in the general surgical regime.
Yeah, I wonder how people manage to do it. Like if they're adapting from one environment to another immediately overnight, there must have been real big challenges around that.
And it's a challenge for nursing because they have to deal with everybody.
Everyone, yeah. Personality traits and people's pain, pressure levels, anxiety levels, isn't it?
Yeah. Very challenging job.
Yeah, I can imagine, because I spent a lot of time as growing up as a carer, going to hospitals and these spaces with family members, and I've always been curious about like the environment, like how does it enable us, and or does it the opposite effect? It doesn't enable us; it makes us inactive, if you like, less active, and it's nothing to do with us. Yeah.
Just one more thing on the hospital environments. For people with physical limitations, they're typically much easier environments than the home environment. When people get home, they find it more difficult.
Is that because of the equipment, or is that because of the environment, or
just the environment is just more cluttered? But you're talking more generally about how it's not just hospital environments. Hospital environments are, on the whole, helpful to people with physical limitations, whereas our built environment is not. And I've given you the example of conference centres. But as a general rule, I remember seeing people putting in little steps, steps that are sort of 2 inches high, which can actually exclude somebody, and they do nothing for the building. There's some kind of artificial aesthetic, this little step, and then they paint it with yellow paint because everybody's tripping on it, not just the people who've got limitations.
Wow.
Yeah.
I mean, it's I something like that, isn't it? So something's, simple, but so problematic, like can cause huge problems, exclusion. Yeah, I didn't really think about those micro
Well,
sort of.
I saw one being put into a building that I worked in, and the cement was still wet, and I was so tempted to just remove it, but I think I might have caused a lot more trouble, but I didn't. But on the other hand, I've spoken to you before about I've had experience of having architects work with us when we've been modifying our homes. And we've done this more than once, and I've worked very closely with architects. And
And these care homes? Are these care
sorry?
homes? Yeah. Are these care homes?
No, in my own home.
Okay,
my own
okay.
private home. So
Yeah.
we've a couple of times we've worked with architects to modify the house we live in, and modernising old buildings. And there's a kind of conversation which goes, so I say, I think all homes should be accessible to people with physical limitations. They say, oh yes, the law says 14% of homes should be disability accessible.
14.
And I say, so 86% of us can't have our friends to visit who happen to have limitations. And also 86% of us, when we get to a certain age and have limitations ourselves, will have to move home. Are you happy with that as a design? And they look dismayed. And then the other kind of conversation, so I've insisted that all of our homes are, it should be possible for someone to come into my home from the street into my home to a chair in a wheelchair. And they should be able to go to the toilet, they should be able to go to bed, they should be able to do all of the functions that are necessary without having to say, I need help. And so explaining that to architects is quite interesting. The other interesting one is taps. Taps. So there's been a fashion in Britain for having taps that are not really functional if you've got arthritic hands, because they require a twist and people can't do the twist.
Yeah.
But they've become terribly popular, whereas the good taps are the ones that you see on hospital wards where you can do it with your elbow. Anyway, so we now have this conversation with the architect, and this conversation took an hour and a half of me trying to persuade them that we should not have these taps in our house. I think I persuaded the architect, but in the meantime, the builder put the horrible taps on our taps. And So we put up with them till the washers needed changed, and then we changed the taps.
I see, yes.
But I don't know if I wore down the architect, but I didn't manage to wear down the builder. But these are conversations I think are really quite important, because there's a way in which we expect people with limitations to stand up for people with limitations. Whereas basically these people with limitations are my friends. Why am I not standing up for them?
Absolutely, yeah. And that's I know it's sort of made that sort of connection around architects can work with psychologists when they're designing spaces. Like, I didn't really realise. Like, I'm like, wow, how psychologists can work, do you think?
Well, there's a classic thing that health psychologists were involved in some time ago, was that people, I trying to think, maybe it was recovering from surgery or in intensive care, have nothing that allows them to know where they are, what time it is, or what day it is, and they don't know if it's day or night because it's that kind of environment. And there was certainly some research that even putting a clock on the wall enabled people to know more about where they were. So the environment can affect the extent to which the person knows where they are in space and time. So I visit someone in a care home, and right in front of her, she has an electronic device that says where she is and what time it is, what day it is, and what month it is. I think that's wonderful, or at least better than what it was before. Really important.
And it's giving that sort of choice, isn't it, to autonomy to that person. I think about when I was working in care homes as a support worker, and people that had different health conditions, physical health conditions, but also had learning difficulties. And even there's a gentleman that was blind and deaf, Like, and how am I going to communicate with this person?
Yeah.
And so I had to read up all the case
Yeah.
studies and find out the best fit support plan and say, okay, well, this is the care plan. And he had his own chair, and he really it had all of the functions that he needed. And if he wanted to sit down, everything would be positioned up for him so he can sit down. And I realized that I didn't need to intervene with him because that was his space, and because everything was doing it, he felt like a see by his smile, even though you can't hear me or can't see me, you can see he was smiling because he was happy in his
Yeah.
space.
Well done for reading up about it, because there's lots of useful information. The other thing you were doing was taking a bit of guidance from him rather than trying to impose your own ideas of what should be happening for him. These are absolutely typically the person with limitations has more expertise than you have, and you should listen. So I have a friend in the village who was going to move into a new house, and she has sight difficulties, and she was going to go and work with them on making the environment right for someone with limited sight. They thought they knew how to do it because they'd read up about it, but she insisted. I was terribly impressed. She was doing exactly the right thing. She was going in, she was teaching them how to make this environment right for her. And it was curious things about getting the light right and making things at touch level and all sorts of things like that that she could guide them on. You might have got from books, but why not ask the person?
Yeah.
Having said that, I worked with someone quite a long time ago who was in a wheelchair. There's lots of stories about what happened with her, but we were putting in a grant and we were talking about we were trying to be correct and call them people with disabilities. And she said, for goodness sake, can we not just call them disabled people? But that language has gone, long gone. People with disabilities was what we said. But before we could employ her, the building that we worked in had to be modified for her so that they had to change all the fire doors because she had weak wrists and she couldn't move them if they were the heavy doors. So all the fire doors had to be changed. And there were also some alterations to some of the steps in the building. But fortunately, the person in charge of the building at the time was very alert to these issues and was very helpful in making the modifications. Whereas I think some other people might have just said, you can't employ her. Oh yeah, I think you'd be surprised at how people would get excluded, and it would be done in such a way that nobody would quite know why they weren't getting the job.
Yeah, I think that's awful. Because we could be there at any moment. I know people who are in that position with their health and their need, and it just shows you that's the society we're creating or we're rewarding. It's a bit of a worry. It's like, that's going to change because we can fall into that space anytime. It affects us all, basically.
There's something else that I think we haven't really spoken about, which is how we use theories to understand people's behaviour. And there's been a tendency so I mentioned earlier the International Classification of Functioning and Disability, and it would try to explain people's limitations and what they do in terms of their limitations in the functioning and structure of their body. That's not how we do it for people who don't have identified limitations. When we talk about people who don't have those limitations, we say that their behavior is determined by their self-regulatory activities, what they want to do, what they feel able to do. So why does that not apply to people with limitations? And we've done a bit of aggregating the theories of limitations, which is our theories of self-regulation. And when you do that and you try and predict people's behavior, the people with limitations, their behavior is predicted just as much from their intentions and their self-efficacy, even more so than for their limitations. So if we put all of these things into the explanatory model, it's the intentions and the beliefs about what people want to do that are more important than the limitations. And it also gives you a different kind of structure for thinking about the issues, because if you're thinking about what they want to do, your model is not one of let's fix their limitations. Your model is then one of what's stopping them doing that. And what's stopping them doing that is not necessarily in their body. It can be in the social and physical environment. And it just opens up your thinking to a model that is much more inclusive of all of the factors that influence human behavior. And human behavior, you don't walk along the corridor because you're able-bodied. You walk along the corridor because you want to get to the other end.
So
It's
yeah,
the same. It's the same for someone with physical limitations.
yeah. I was just blown away by what you said, because like I never really dived deep into that perspective. So what would you say?
We can be discriminatory in the models that we use.
Mm,
So if we always use a model of disability to understand the behavior of people with limitations, we're being discriminatory. If we always are investigating their problems rather than including them as ordinary functioning members of society, we're using the wrong. We're not using the wrong theories.
yeah.
We're using discriminatory theories.
Yeah, I think that's a powerful point, isn't it? It's like there's nothing wrong with these people. They're just human beings who are functioning in this way, and then we have to shape the environment that we all can move or to interact, right? Rather
Yeah,
than seeing something as problems.
I'll give you another example. Quite a lot of what we study as health psychologists as a behavior of patients, but we
Mm.
also study the behavior of health professionals. Now, if you look at the history of how we've done that, when we study the behavior of patients, we're looking for models that are looking for people thinking incorrectly or in some way biased in their thinking. Whereas when we look at the behavior of health professionals, the models are usually, it's not going to be corrected by behavior change. Typically, the models are about education and knowledge. It's not about anxiety and biases and irrationality. And we use a different kind of theoretical framework when we look for these well-educated people who are providing healthcare from the models we use for our patients. And actually, on the one hand, it fails to serve the patients well because they're being driven by the same rational decisions about their behavior as the healthcare professionals. But equally, it means that we don't necessarily incorporate into our thinking about healthcare professionals things that go beyond education. So when I was being encouraged to think about interventions that might enable dentists to produce better healthcare for children, the dentist's idea was that we give them more education. My idea was that we treat it as a behavior problem and think about it in the way you think about any other problem in any other group of people. And so we did a trial in which we contrasted education from rewards. The psychological model said reward the behavior. The medical dental model was you educate the people. Education did nothing. The rewards did it all.
So
And
okay, yeah.
so basically, if you use the wrong model, you don't get the. If you use a model, if you restrict your model of human behavior, you restrict your opportunity to understand and to change.
Yeah, I think that's because that's the starting point, isn't it? To understand what's so if we don't, if we're not looking, if we got those issues, if we got those sort of filters on and those sort of blind spots we're just ignoring, and we start to design something, and then of course there's going to be gaps.
I'm talking in a very pious way, but that's because, of course, I'm not really aware of my biases.
Well, this is what I thought might be useful for the audience to elaborate a bit more on, because I think that was really interesting. Difference between irrationality and biases. So, and I know that when we design stuff, we have our own, sort of blind spots and biases on. And then irrationality, what do you mean by that? Do you mean the person has to think about, is this going to work logically? Like, how do you mean by irrationality when they're considering?
Well, when people are talking about it, they're talking about people having wrong ideas that conflict with the truth, or that they're thinking it through wrongly.
And that means, you mean the patients are thinking wrongly, or just the general?
This is not something I've thought about in a particularly strong way. It's just I just want to make more of a contrast between the kind of theoretical models that we apply from one subgroup of people to another. So people with physical limitations versus people who haven't, people who are in the highly educated professions versus those who are not. Our choice of theoretical model can be biased by some kind of presuppositions about what the determinants of behaviour are in people, rather than thinking our theoretical models, if they are about how people set goals, choose behaviours, deal with challenges in life, they should be relevant to everybody. And if we don't use the same models for everybody, we need to know that we're not doing it and why we're doing that. And there may be occasions when that is the right thing to do, but I would like us to be a little bit more aware of it.
Yeah, absolutely. I think, when you think about the starting point, isn't it? It's like, well, we need to have all of the tools available to us.
Yeah.
But if you must be selective, we're missing all this. So why do you then think then people skip that part or just ignore that? Is it because of lack of awareness, lack of knowledge, lack of why do you think they just don't do that bit about?
Yeah, we get back to something very fundamental. How do people choose the theories that they use anyway?
Yeah.
And all of our prejudices come into that, I think. And in a way, that doesn't bother me too much, except when I feel that it's actually restricting our ability to be helpful because we've biased our thinking too much. But I mean, the other side of it is, as a researcher, you do have to specialize because you can't be on top of everything at the same time. But if you're working in a practical situation, you need to have quite a broad way of thinking about things and try not to be too biased, I think.
And is that something then, I suppose, in reflective practice, then is it an uncomfortable thing to do, to go through those thought exercises, be aware? Why do you think people don't do that bit of awareness? Is it because it's too uncomfortable for them, or do they think it's not important? Why do you think they skip this bit? Very interested in the psychology around this.
Oh, well, you're asking, why do people do things?
Yeah.
Yeah. And they do it because they've always done it. They do it because they observe other people doing it. They do it because of the rewards in society or for doing it in that way. There's nothing special about that behaviour in a funny way. You could actually do a study of how people choose theories and get a theory of how people choose theories. Sorry, that's a bit meta. But it's just another human behaviour.
Yeah, because I got students who I'm supervising, and they're always looking out for the choosing for health-related topics up in Sunderland, because we've got massive health inequalities up here, and it affects lots of people up in the northeast. And so they come with these ideas of access, about services, about the environment, about health outcomes. So I might propose it now and again about this idea around looking at how people choose health theories. I suppose is it more researchers or health professionals or health behaviour professionals?
Well, I think the researchers have to specialise.
Yeah.
That's just making excuses for us academics, isn't it? On the other hand, the problem is if everyone focuses on the same things, I'd like to think other people were focusing on other things. So quite early on, when I was proposing disability as behaviour and thinking about it in that way, some of the sociologists were challenging me that there was an implication in my model that it was all driven by the individual rather than by society, which is not how I was thinking about it at all. But it was quite nice to be challenged by another discipline. I quite enjoyed that. I guess it makes you aware of it. May or may not be in your thinking, but it may appear by what you say that you're more prejudiced than you think, or you may be more prejudiced than you think you are. But it certainly wasn't how I thought about it, and they were calling me up to justify how I was doing it.
And how would you say health psychologists or health psychologist training should consider this, this area? So if they were listening to this podcast and saying, okay, well, how do I be aware of my own biases, advantages, privileges that might be influencing what I'm writing or what I'm thinking, what would you suggest to them? How would they think about that?
I haven't a clue. I don't know how to think through that. I think you're probably much better at thinking about that than I am. And I'm not typically, I haven't been in a training role for quite a long time, and the students I taught, so obviously I've had PhD students in my own discipline and a little bit of master's student teaching, but most of my teaching has been to medical students. And so I think I'm not too aware. Medical students assume that they're going to deal with everybody. But I certainly had noticed that there were medical students who couldn't deal with guys that couldn't deal with working with women.
Yeah.
And would say gross things like they would refer to a particular task of, well, that's women's work. That was the one that became a big issue in our medical student teaching. And they came from a culture where there was a thinking that was women's work. And it was just, I spent some time with that student just discussing the fact that in their working life, they'd have to do a lot of working in teams where there were women, and they would have to think about how they dealt with that as an issue. And just pointing out to them that they wouldn't qualify as a medical student, however good they were at exams, if they couldn't relate effectively to other people in the team, the healthcare team.
Yeah, absolutely. Especially in healthcare, you have to talk to everybody.
Absolutely, yeah. But I think you're probably better at thinking about the issues than I am, because it seems to me that it's part of your everyday teaching experience. On the other hand, I think you may also have the environment in which you can get the students to teach each other. If you've got a full range of students, because people can explain things to each other better than an outsider can explain it.
Yeah, I mean, we do have things like what we call peer-assisted learning. It's programs that so students do end up leading some of the sessions, and they teach their peers are coming on, give them confidence, and give them like the know-how. And some of our students end up becoming taking on obviously PhDs, becoming lecturers, academic tutors. And it's really good to see see the growth. But I did want to answer this other question, which is might not have to go into too much detail, but it's going back to the person who might be experiencing as a consequence of the built environment, and trying to focus on the humiliation bit, the embarrassment, the people feel excluded, the feelings of these people. How do we, I suppose, really highlight that and do something about it? Because just to give you one example of the built environment is, so I was working in weight management some years ago. So I had people who are BMI really high, so body mass index was really high. For them to lose weight, they had to come to this program, and if they didn't come to this program, they won't get their surgery. But this patient, particularly, I remember it was a very humiliating experience. They got stuck in a lift, and it was very, we had to do different types of interventions and calming the person down. But it's stuff like that, you see, like I was there as the health professional. We had the building, the booking was done by our public health team. So everything was, but when the person came, didn't know what the person was. The person got stuck in the lift, and the lift only carries. It was a graded building where we had the session, so it could only take so much weight, that lift.
And I imagine you didn't think about that in advance. When we've done that kind of weight management program, one of the interesting things is getting adequate chairs. That they have to be weight bearing a certain size, and that there's a limit to how many people you can get in a room, and all of those things. But I don't think I would have noticed that the lift didn't take the weight. So that was rather bad. So I think you just deal with it by telling the person this is something we'll have to remedy in future. It's our fault.
Yeah, like I said, I got very there's a very sharp learning curve on that one. And you just realize, like, we missed that one completely. I felt like I think the patient did feel calm and they felt respected, but in that moment, the humiliation like I was trying to keep the conversation distracted, so other people are not looking in, and because it causes a big scene, these people are, cannot help themselves in that situation because of the environment. And
it's whether you are thinking that the problem is the persons or the environment. So it's the environment that has the problem.
yeah,
The other thing that I find quite helpful in these situations is, do you know the Leventhal theoretical model, which has the parallel processing of when faced with a challenge, like being stuck in the lift,
okay,
there's two things you deal with. One is you deal with the problem, and the other is you deal with the emotions. And
yeah,
if you work within that model, you very quickly realize that usually the best way of dealing with the emotions is to deal with the problem.
okay,
And so that in some ways, if you start reassuring the person, you're kind of locating the problem within the person.
yeah, okay, yeah,
Whereas if you talk about the bad environment, then you're locating it outside the person and you're in the problem solving. You're on what I call the top line of the model rather than the bottom line. And the bottom line is the emotion focused thing is what you would do. Really, my belief is that's what you do when you are not going to solve the problem. You then try and manage the emotions better. And there are situations where that is the right thing to do. Can I say that I'm not the good person for that? My husband and I have a discussion about that when we were both working with agoraphobics, I would have, I'd be indignant and say, we must solve this, whereas my husband would say, that must be terrible, and be sympathetic.
I like that strategy. Yeah, I think that's what's the word? Must have a less stressful life.
We're just different people, so Derek would be very much better at the lower level of the model, and I'm more on the top level of the Leventhal model.
Oh, I think it's really useful for our listeners. What's the name of this module? The model.
It's Howard Leventhal self-regulation model, common sense self-regulation model. Oh, you must teach that to your students. It's such a lovely model. And we had a celebratory event for Howard Leventhal at the International Congress for Behavioural Medicine last month. And I was very happy to be there and praising the usefulness of his theoretical model. And we've applied that model to looking at how people started to think about COVID. Because it identifies what the challenges are when you're faced with something like an illness. That there are five ways that people commonly represent an illness. They say what it is, what caused it, what the consequences are, how long it's going to go on for, and how it can be controlled. And if once you've got those five things in your head, it's really useful. And somebody talking about any illness will run through those things. So they'll say, I've got a cold, it's given me a runny nose. I got it because I stood outside in the rain. It's been going on for days. I've taken some paracetamol. It hasn't worked. It means I haven't been able to go to my work. You've got all the five things in that sentence. It's just how people speak about illness. And so it's called the common sense model for a good reason.
No, it's really, so I might definitely look into it because we also do master classes for these are basically for young people, and health is a big problem here. So if they want to know about how to change and how to address. So health psychology seems coming out, and we're doing this master class next year. But I think they're year 10, year 11, and year 12s in that age gap. So shows you how they're thinking ahead.
Yeah.
One
of the things when you're talking about the weight management, the other thing that weight management often does is they want an environment that encourages people to walk and cycle, which very often makes it much more difficult for people with limitations of movement. So that when you put in cycle tracks, you put in new curbs, you make it more difficult for them to cross the road. Everything's just a little bit more difficult. When you make the lift less accessible than the stairs, the person within the wheelchair has got to go around the building and find where the lifts are. So we've got a dilemma between enabling physical activity in those who can and enabling other people who've got limitations to move effectively. It's the same kind of contrast as we have when we talk about limiting eating. are we creating people with eating disorders? It's getting that balance whereby your preventive efforts don't cause trouble for other people.
Well, this is it, isn't it? It's like you don't want to you have one problem and you just address one problem, it starts creating 4 or 5 problems. Like, well,
Yeah.
you'd rather just letting that person have that one problem rather than creating 5, 6 now.
I actually don't know how people are going to resolve the issue of. We maybe need to look to other countries where have more experience of putting in cycle tracks to ensuring that things are accessible for people with limitations. We've been quite good at putting in the kind of surfaces for people who've got sight limitations, but I think the built environment has a lot to answer for.
Yeah, I think so. I think when it comes to people having health problems, like members of my family, people that I've worked with, I used to think it's more individual rather than environmental. But now when you're looking at more closely, like years and years, you're like the service access, the infrastructure, the architecture, if you like. You think people are just doing their best to get into these spaces. I'm like, why can't we just sort the spaces out, and then those people, you don't have to change the people, it'd be easier. You know,
people don't necessarily do their best to get into them. Very often they avoid these spaces. So the people running the spaces don't realise there's a problem because the people who would have difficulty stay away. So that they're excluded because they don't have access to the same facilities. They pay the same taxes, but they don't get the same facilities.
Absolutely, and it's almost it's there in the data, isn't it? You can see who's accessing it, so it's not, we're not imagining, it's in the intelligence. And
also when you go abroad, there are when you go to other countries, you see more people out and about in wheelchairs. Britain, I think Britain is particularly restrictive.
Is it because of, like, I don't know, the culture we have here, the infrastructure, our attitudes towards people in the space we don't really care about them, we don't really see them, so it's not really our problem, and we just have this attitude. Just think, why is it like this? Probably a combination of factors, but
I think it's to do with our attitude towards the built environment. We value our old buildings and we don't want to change them. We have beliefs that things can't be changed.
Is that because it's too much effort? Is it because, like, it's too stressful to think about it? If I'm not going to think about it and I'm not going to solve this,
well, I think people don't see it because it's not there. So what the eye doesn't see, the heart doesn't grieve.
The seeing is believing.
Yeah, and you can make it. You can construct an environment where you don't see things. It's the same kind of thing when you, if you're looking at poverty, and you see poverty. There are clusters of poor people and clusters of rich people, and the rich people don't see the poor people. I think the poor people may barely see the rich people because they're just in restricted environments. Nobody's restricting them, but they can create these kind of, I would describe it as almost ghettos. That there are middle class ghettos and there are council house ghettos. We don't mix it, so people don't see it.
Yeah, that's interesting. Absolutely. So when you have certain areas, like even where I live, you can see the people with the life expectancies are the ones who've got the most acres of space right on the edge of the town, if you like. And then when you go inside in the urban, really urban, we've got multiple different occupancy and house occupation, a lot condensed, less green space. You see, and I was born in those areas. So when you're born around those areas and you grow up in those areas, you know, where you play football and stuff is basically on the road. You don't go to the parks because it's too far. You're looking about 40-minute walk. We play on the road.
Yeah, I'm from a working class family, brought up in the council house. Mind you, I loved all of that, and I miss some of the community aspects of that.
So that's not, isn't it? It doesn't have this isolation, loneliness in those spaces because you're more connected.
Yeah.
It's getting that balance right. So do you think then do you think it'll change then that with concept of AI, artificial intelligence will tell us a bit more about this stuff, or do you think humans will just be the same and it'll be gradual increments? It won't be like a
Artificial intelligence won't tell us the answer to questions we don't ask. So that I think that it's not going to progress things unless we've got an evidence base to use to investigate. And at the moment, I'm not absolutely sure we're creating that evidence base. But that's why you're doing these podcasts, isn't it? To encourage people to look more broadly.
Yeah, and because we know, and to search for those questions, and I think it's such a good point you make. Like we have to think about the question in the first place. If we don't answer, then it's never going to come up with the answer. So I think, yeah, this resource, this podcast, is hearing the different voices around it.
Having talked about the council house situation, I was the one who went to the grammar school because I passed my 11+. But then I had people calling me names for being that.
Oh, really?
You know, I mean, that's all. In retrospect, I mean, it didn't bother me at all because I was in a privileged position. But they call you a high school snob, that kind of thing. Nothing lethal, nothing like what people are getting on social media. But it was quite interesting that was the way the discrimination went.
Wow. So, and who was it from? Like, was it from, I presume, adults rather than children?
Well, no, it was people of my own age. Yeah.
And that is taught, isn't it? Like those sort of attitudes are taught or conditioned, right? Why do people have those formations in the first place? Is it?
Well, I think if you want the social psychologists who work on in-group, out-group issues, I was falling out of the in-group, wasn't I?
Going against
and you can always discriminate against the out-group, whoever they are.
Yeah, because you don't identify with them, isn't it? And is it then like after when you went through these experiences or this, like you just thought, no, you became more, did it reinforce your motivation to work in this space or talk about this problem?
I don't think it changed me because my parents had always had this attitude of valuing education. So I was just doing what the family thought was a good thing to do. And so it didn't really bother me. And in retrospect, of course, these people were, the person I'm thinking of in particular was going to have a much more challenging life than I had. So her calling me names was nothing compared with what she had to deal with.
Yeah, I wonder if that will ever, like the language, how we describe others and put them into those categories and labels.
Yeah,
that'll probably continue, right? Do you think
this is where you really want to talk to the social psychologists who understand how in-groups maintain themselves by having a language that supports what they do and talking badly about the out-group. And if you look at the moment we're in the political party conference, and what each political party does is spend some time attacking the other party. Because that maintains your in-group, because you're identifying the bad things about the out-group. But I'm not your expert on that. You want?
No, thank you for like even giving me that sort of insight, because I think you can never health is. I suppose this is a question for a different day and different podcasts. But I don't think you can here in the UK. You can't really separate the politics from health, because health and education and the economics are the key tools, if you like, people use to get people's votes. Health, education, and employment.
I could let rip on that. I don't think you want that on the podcast.
Maybe it's a comment. Yeah, it's a comment.
I can't bear the thought that people are now being discriminated in terms of having to pay for healthcare if they want it in time to actually be useful for their health, and that poorer people are being delayed and may not get the same results from their healthcare. It absolutely horrifies me. But you're on to absolute politics now.
Yeah, and it's a respected discussion that we have in a different space, and I think we don't want to do any disservice to it or injustice to it by just like diminishing it or just like not talk about it in detail. But yeah, for the purpose of this podcast, you're giving so much insight into how people should consider the built environment. I think that's how I've got from it, like lots of, from a theoretical perspective, from a practical perspective. So lots of things for our listeners, current psychologists, health psychologists, or even other health professionals or members of the public might really find this interesting. I did want to ask one final question then for the end of the podcast before I say thank you and goodbye. Is there anything that you would like to add for listeners to really consider? I think you've said a lot anyway, but if there's any particular focus that you'd like to add or anything that you've missed or want to contribute to add here?
I just want to say that this is not an issue I really think about, and you've made me think about it a little bit more, and I haven't thought about it in great depth. But I realise that there are things that happen right through your academic career where you're actually making discriminatory actions, and in your private life you're making discriminatory actions, and it's just worth being aware of them. And also the fact that you're pinpointing the fact that maybe one should be more active in doing something about it, and that's not what I've been doing. But I like the fact that you're doing these podcasts. I think that getting people to think about things that they may not have thought about before is really quite useful, and highlighting issues. So thank you.
No, thank you, Marie. It's a very pleasure to have you on, because you have been in the industry for some time, so you would have seen stuff, and it helps people like us, like, well, what should it look like? What did it look like before? What should we do, and how do we do it? We don't have all the answers, and that's why this space is there to share the intelligence and that knowledge exchange. So people will say, okay, this is how I can do, this is how I can make a difference. This is where I should focus. So thank you for sharing like the wisdom, because I would not known that stuff, and some of our listeners may have not got that stuff through books and journals in such a very articulate way. But no, thank you. If anyone wants to get in contact with yourself, I'll put the details in our podcast. They want to reach out, have a conversation. But thank you so much for coming and speaking on the podcast. I'm sure we'll see you around, and I'm sure there'll be another episode in the future. Thank you, listeners, for tuning into this podcast. Equality, Diversity, Inclusion in Health Psychology. My name is Dr. Jolel. I'm joined by Professor Marie Johnston. If you want to get in touch with either of us, I will leave the details. In the meantime, take care, stay curious, and stay safe.
Thanks, Joel.